There we go. Hey everyone, how's it going today? Hello, hello. Oh, awesome. Dependable viewers. Great. Well, and Kylie. Here. We got a free blog after me. That's pretty good. Behavioral health tomorrow. Not in behavioral health tomorrow. I think I reviewed that. Yeah, nice to have you guys here. I was so excited. I had like 605 subscribers, so thank you all for that. Again, it only helps to boost my my serotonin levels a little bit there, so it's nice to. Hey, Abby. We'll get started here in just a few minutes. We're at 102,000 views overall. Wow, that's pretty awesome. I think I've been doing this like 5-6 years now, so yeah, it's a lot of videos I've put up there for sure. Kind of nice doing them live now because now I don't have to like go and edit and upload and all that jazz. Just go straight up to the cloud. Hey, Shelby. You guys had a nice lunch. You're all charged up. Hopefully not having too big of an insulin rush. Paige, hello to you as well. Jackson, you can absolutely take all the credit for half of those views. If you watch them that often, then I appreciate it. Again, I make no monetary gains off of this. Just nice to see that views are going out there. Yeah, when we were on campus, I always did it live, and then I would record it at the same time. It was just audio over the PowerPoint, and then I would post it up afterwards so people can go back and watch it. Yeah, so I'm always live for you guys. They do say I'm a natural cure for insomnia, so the FDA is doing some investigations to see if they could market my videos for sleep help. Good. I'm glad your boyfriend can prepare for the eventual future. Maybe not eventual. I hope not. Yeah, I do love the Fallout series. It's one of my faves. New Vegas for sure. One of the top ones. Probably of all games, actually. Got to. I don't recall what slide we got to. I think it was. Yeah, talking about community versus hospital acquired. I did have a question over here on the board. Be careful, Kaylee. That Stardew Valley can suck 100+ hours out of you without you even knowing it. Dangerous. Oh, I'd ask you which the population you might be trying to romance, but I don't want to get too getting into those kind of topics here. But I've had a couple playthroughs. Fun. Anyway, let's get started here. So, let us begin talking about this question we have here. So, someone's mentioning Kind of review what I mentioned with organ transplant, brain dead patients having to do with levothyroxine. Yeah, so married Penny, my wife rags on me about it often. I was a big Abigail kind of guy, but I think it goes back to my goth slash emo upbringing in high school. But another topic for another day. Anyway, so looking at patients who have undergone some illness or something to where they're now considered clinically brain dead and are able to donate their organs. A lot of their functioning in terms of like autonomic function, in terms of endocrine function, really kind of goes out the window. So like they can't regulate things like their blood pressure, so they're frequently on vasopressors, which we'll talk about a little bit later in this course. You'll find that things like they don't release antidiuretic hormone anymore, so we have to replace that by giving things like vasopressin. So all these things that we have to take over for, and that's what TransLife basically come in and does. You'll have these nurses that will come in, they're working under these protocols, and they'll administer these meds under certain guidelines and whatnot to keep the patient prepared for eventual organ harvesting. And so one of the big things they use is IV levothyroxine. That's one of the few instances you'll actually see that being used, but 9 times out of 10 it's going to be oral. But yeah, it's pretty sad to see when it happens, but then it's also, you got to think about the upside that those organs get to go to people now who can potentially use them, which is good. There's actually some pretty wild tox cases of people who've overdosed. I think it was baclofen, she was actually pronounced brain dead, and basically went to the OR to have her organs harvested, and then like woke up like very close to the incision time. And it was just this like really severe coma that was induced by this baclofen overdose. So again, don't do drugs. Don't overdose on drugs. It's a bad idea, I would say, in general. Okay, but if you have other questions, feel free to pop them up. So we were talking about acute kidney injury. Again, you can find this may happen more in the community setting. More often than not, you'll probably find a lot of cases of an iatrogenic nature, or just as a result of their progression of disease in the hospital, in the ICU sort of setting. If it's community-based, it's usually due to things like volume depletion. So if someone's had like pretty severe nausea, vomiting, they're becoming septic, and they're say third spacing fluids out of the vasculature just due to having those leaky capillaries due to inflammation and whatnot. And then you can also see quite a few medications that can cause this, and this is why I talk about patients who may have an acute on chronic renal failure. So they have kind of chronic kidney insufficiency, and then you have sort of a new insult added on top of that, like an ACE inhibitor, a diuretic, maybe an NSAID even, can lead to this. In the hospital ICU kind is generally going to be more so of like an intrinsic nature. So you can see here, from the community side, it's more going to be a pre-renal issue oftentimes, and then in the hospital ICU, it's going to be more of an intrinsic issue, generally speaking. You'll find that pretty commonly. But what are some things we can see in terms of risk factors? Certainly, these things I think are probably pretty intuitive. Things like advanced age, critical illness, things like that. Some of these things we can change, and some things we can have some intervention on. So if we can get them off of nephrotoxic medications. So for instance, if you had someone who had pre-existing kidney injury, and they're coming into the ICU and they're febrile, say due to sepsis or something, maybe not using an NSAID, maybe using an alternative like Tylenol to see how that would work for them, right? Obviously, certain things you can't really change, such as their ancestry and things like that, their age, so some things you just have to kind of roll with as the case may be. So as I mentioned, with the pre-renal acute kidney injury, this is due to hypoperfusion of that renal parenchyma. Again, the kidneys do require a lot of oxygen because they have all those transporters and things that are constantly working to help to filter and secrete things, reabsorb things from the renal tubules. And so if you have some cause for hypoperfusion, which may be due to like blood loss, it could be due to volume loss from a GI standpoint, diuretic therapy, things like that. Again, you just have less volume to send to the kidneys, and again, your body is preferentially going to be perfusing the brain and the heart. So things like the GI tract take a backseat to that. Things like the kidneys can take a hit. And so, along with things like sepsis, all that, even some other cases like renal artery occlusion, you can find that you will diminish the amount of oxygen being sent to the kidneys, and you can reverse this, right? So if it is a relatively short period of time, you can just give more volume in a lot of cases and then fix that issue. However, if it's more long-standing, you will find that kind of longer depletion of oxygen to the kidneys will then lead into an intrinsic sort of issue, as you'll find. Yeah, so someone said they should have used baclofen instead of ACTZ in that movie. Perhaps, I believe you're referring to Wolverine, X-Men Origins Wolverine. Again, I just said beta blocker. That'll slow your heart. That'll make you look dead, right? So typically, like prerenal kidney issues, you do have a lot of compensatory responses. So we know things like the renin-angiotensin system, antidiuretic hormone, all of that's going to be really helpful here. We're also going to be doing things like prostaglandin production to help induce that afferent arterial dilation. And you'll also have angiotensin 2 basically squeezing down on the efferent arterial in order to keep the pressure at the glomerulus higher and allowing for more filtration to come to occur. However, these can be overwhelmed, and you'll see again how our medications can be fighting some of this. Like if someone had an NSAID or an ACE inhibitor on board, it would be sort of fighting this and can lead to those compensatory mechanisms again being overwhelmed, and then you're hyperperfusing the kidney. So functionally, we can there's functional causes here we can see. So things like ACE inhibitors and ARBs, like I mentioned there, this can be worsened in patients with like renal failure or renal artery stenosis. With NSAIDs, you see that this is going to be worsened by things like chronic kidney disease or hypovolemia, meaning you're just having less filtration happening anyway. And then an NSAID just clamping down on that afferent arterial just makes it even worse. And then one thing we have to think about too are going to be vasopressors. And we'll talk more about this, I believe, either in the surgery section or later on. But these are drugs designed to increase blood pressure, especially for patients who are hypotensive due to sepsis or something. These are things like epinephrine, dopamine, norepinephrine. When you increase those vasopressors, basically one of the organs that are going to have decreased perfusion will be the kidneys. And so this is a very common thing where patients will come in who are septic and you're having to give them vasopressors to increase their blood pressure, but then inadvertently you're also causing kidney injury as well. It's one of those things you kind of can't help, because if they're really hypotensive, like, they're not going to be able to perfuse their brain, the heart, all those really important organs, and thus they're going to die, right? So it's kind of have to take the good with the bad there. As I mentioned, generally speaking, prerenal AKI is going to be reversible. However, if it's more long-standing, that can then lead to direct injury to the parenchyma, can lead to more of an intrinsic sort of issue there, right? With intrinsic, you'll find that it can happen at various levels. So it can happen to the vasculature surrounding the renal tubules, the glomeruli, the tubules themselves, or the interstitium. And you may find that different drugs here may be affecting the kidney at various levels here. So in terms of like the renal vascular damage, this could be due to things like emboli that could be occluding this. So for instance, if you had something like an embolus that was dislodged during surgery, you'll find the smaller vessels can also be occluded as well. And this can be worsened by things like hypertension, which can, over time, we know compromise that microvascular flow, right? Because we know chronic hypertension leads to kidney injury as well. So that could just kind of help to worsen this. With glomerular damage, here we're going to be finding this is relatively rare. We'll talk a little more about this later on. But the tubular damage, this is where we're going to see a lot of the acute kidney injury actually happening here. Most of this is due to prolonged renal ischemia, due to prerenal issues, right? So about half the cases there are caused by a prerenal problem in the first place. But the rest of them are going to end up being caused by tubular toxins, right? Not like tubular, like awesome. If any of you are old enough to remember that descriptor. But more often than not, we're going to see things like hemoglobin, uric acid, myoglobin. We just had a patient a couple months ago that I was working, doing some medication orders for, and they had hemolytic uremic syndrome. And that one of the problems with that was that their kidneys are starting to fail now because of that. And they end up having to go on dialysis. Things like contrast agents and aminoglycosides can also be pretty notorious for causing this as well. And again, this is because the kidneys are highly metabolically active. They require a lot of oxygen. So, preventing them from utilizing oxygen for a period of time is going to lead to this tubular issue. So what is going to be happening here with this initiation phase that happens is you'll have some initial injury, maybe due to ischemia or something like that, that leads to apoptosis of those cells, right? It causes necrosis to occur here. Sort of the downstream effects are going to be that you can't regulate fluid and electrolytes as well, right? So now all of a sudden, maybe you're spilling out more sodium or potassium than you mean to, because those cells just aren't there to reabsorb them like they normally would. We can't regulate the fluid, reabsorbing it or secreting it, as the case may be there. And you will find that as well, things can get clogged up. You can develop these casts here, especially with things like hemoglobin or myoglobin. in the renal tubules, and this can take time. But what you will see here is that you'll have impaired urine concentration, you'll decrease urine output, and GFR is going to be overall reduced, right? If you recall, we'll talk a little bit about calculating GFR later. But these are the big things you're gonna be looking for. Looking at the urine analysis to see what was going on there in terms of concentration. Looking for things like urine output. Usually for adults, we look to see like 0.5 to 1 ml per kilo per hour is generally considered good. And then you'll see that GFR that will eventually catch up to that. And again, hopefully you can have some recovery, but it may take some time, weeks to months potentially. So with interstitial damage here, you can see that this we'll talk a lot about because a lot of medications can be at play here. And so infections can do this to autoimmune diseases, certainly things like lupus nephritis and things like that. And you'll see that generally speaking, we can deal with this if caught early. We can treat this pretty easily. If it's medication induced, especially, just get rid of the medication, switch them to something else if possible, or treat the infection or whatever the case may be. For a lot of autoimmune diseases, we do things like corticosteroids, or we'll do things like immune globulin we can give to the patient to help decrease that inflammation, and that does help to improve their kidney function overall. With post-renal AKI, this is pretty uncommon for the most part. There's a few things that will cause this obstruction, though, so things like BPH for patients with prostates being one of the more common ones there you can see. But interestingly enough, you can see some issues in terms of medications. So for instance, oxalate crystal deposition, right? So you could see this in patients who maybe are, one of the things I always think about is going to be with patients who have ingested radiator fluid. Radiator fluid actually can lead to having calcium oxalate crystals being formed, which you can actually find in the urine and the kidneys there. That could be one rare case for that happening there. More often than not, though, you can see this as well with drugs with poor urine solubility. So think about things like methotrexate. How if you don't give that with enough fluids, and acyclovir is another causative agent here, you can find the drugs will precipitate out and can lead to that obstruction and lead to that problem there. Another big one you'll see is tumor lysis syndrome if you work with oncology patients, because as you give them the chemotherapy to start to break down all of those white cells, especially for like leukemia, you'll find that they are just spilling out all this uric acid, they're spilling out all this debris that can eventually clog up the kidneys. So tumor lysis syndrome is really can be a big kidney problem, as you'll see there. Someone's asking what can you repeat what ATN is? That is acute tubular necrosis. So again, that's more of a interstitial type of kidney injury due to the tubular damage happening there. So the cells are basically dying off. So if I ever put an acronym on there and I don't explain that, I apologize. Just go ahead and call me out on that, and I'll certainly do that. Again, you guys know how these patients are going to present. You're getting that from Dr. O for sure. But, things like decrease, urine production, things like changing color, especially if they start to have, a brown tinge to the urine, maybe indicative of things like myoglobin. Like I always love those posts online where it's usually around January and someone like goes and works out for like the first time, like they do like CrossFit for the first time, and they've been like a couch potato their whole life, and they show a picture of their urine, it looks like tea, and they're like, is this normal? And everyone's like, go to the hospital, you have rhabdomyolysis. And they're like, I'll be fine, I don't have insurance. And then eventually they do go in when they realize that they're in pretty big trouble. But those may be things that they may first notice there. Certainly weight gain due to just holding on to more fluid. And when you're evaluating these patients, you want to be looking for things to see, is this an acute problem? Is this new for them? Is this more of a chronic issue they've been dealing with, or is it an acute on chronic problem, right? So this is a big thing I always like to ask about, especially when I'm getting consults for like tox cases, is, the provider, whoever is consulting me, whether it be a PA or doc or whoever, they go through and they say, okay, the patient's serum creatinine is 1.5. I want to know, that's high, right? That's higher than what you would normally expect. And this may be important for things like, whatever they overdosed on to get cleared, if they can't clear through the kidneys. I want to know, is this new? Is this something where they have previous records that say, okay, well, normally they sit at 0.6. Now they're up to 1.5. That's a pretty significant jump. Or is this their normal, right? So they can give me a lot of clues in terms of what's going on in terms of the renal function for that patient there. Or maybe they sit at 1.5 normally, and now they're up to like 2.8. Again, that could be a sign of an acute on chronic problem that may be caused by something like a drug overdose or something like that. Typically, this is a lot easier to determine inpatient than outpatient because you have a lot better access to information. You know kind of what their delta was from when they came in to now, where you're now seeing them and noticing this problem is happening here. Asking on an outpatient basis may be more difficult because the patient may not have good recollection of things, may not have all the medical records available to you. It's always a really big challenge, is when you see an abnormality, you want to know, okay, is this new or not? And if you don't have any old records, you may not be able to figure that out, unfortunately. So again, you want to be asking about things like chronic conditions that they have. Do they have diabetes, which, you know, may lead more likely to have kidney injury, their medication history, laboratory studies if available, you know, things like especially recreational drugs, OTCs, herbals. There's a whole rash. If you guys don't recall, but several years ago, back when the bath salts were really starting to pick up and were becoming a big deal, there were several different amphetamine-like drugs that people were utilizing. There's one, I believe it was called In-Bomb, like in-bomb. And I don't remember the chemical name for it itself, but I remember there's a really interesting case report where there's a couple of people who were taking it at like a music festival or something, and then they were transported to the hospital and had severe rhabdomyolysis due to this, you know, the horrible effects of this amphetamine they were taking, causing all kinds of hyperthermia. You know, some of them required dialysis, some of them required permanent dialysis because of the renal injuries due to these recreational drugs, right? And so those can be really difficult to know what they're even taking because, you know, they may not be all that honest with you in a lot of cases there. But ask about herbals, ask about OTC stuff to give you kind of a better idea. And of course, we talked about the trend of laboratory data as well. So during this evaluation, remember serum creatinine does have its limitations. It's not perfect. Know that it can vary with age, with gender, muscle mass. We talked about with kids how very young ones like infants don't have a ton of muscle mass, so their creatinine may not be all that useful because they don't have a lot of muscle for it to be produced, right? Their diet, if they really have a high protein diet, that can increase the amount of creatinine they have there. Maybe they're supplementing with creatine or something that eventually gets converted into creatinine. Hydration status is also another big one. If they're really dehydrated, you'll find it can tend to concentrate that. Amputation is actually a really important thing too. If you're thinking about patients with like diabetes or something. Shelby's saying one of my rotations for my RD internship was at the transplant center. We had a patient that was a teenage male who damaged his kidneys from too much protein. Wow, that's really interesting. I don't know if from like a, you know, weightlifting supplement sort of standpoint or what, but wow, that's really interesting. So again, don't need too much of a good thing can certainly be bad in a lot of situations, but so the amputation is kind of really interesting. So imagine you have like a diabetic patient who is like really not well controlled, and you know they're in the ICU because maybe they developed an infection or something like that, and basically they have a history of you know bilateral below the knee amputations because they had such bad diabetes and developed, you know, really bad infections, whatever. They took off the legs, you know. So that type of person there, you would expect them to have kidney injury, right? You expect to have chronic kidney injury because if that bad of a diabetic where they've needed amputation, their kidneys are probably have not been spared during that time, right? So you can take a patient like that and end up getting their creatinine level, and it may look like pretty good. It may look actually kind of like normal, but you have to consider that patient has a lot less muscle mass than they used to because they have the bilateral below the knee amputations, right? So in some cases, you have to consider, are these creatinine levels reflective of what's really going on with the kidneys, or are they maybe falsely elevating the GFR? And I may be, you know, having a false sense of security there and saying, okay, well, the patient's kidney function looks pretty good. Let's go ahead and dose the drug like this, when you really shouldn't be doing that. Or for instance, like if you have, like you'll have patients who are 85 years old who have like no muscle mass whatsoever, and you get their creatinine and it comes back and it's like 0.6. It's like, well, they must have great kidney function. Well, it's because they don't have any muscle mass left to make the creatinine. And so in those cases there, you may want to be a little more conservative. And one of the rules of thumb that I learned when I was in rotations and whatnot is if you have a patient like that, very elderly, their creatinine is less than 1, I usually just bump it up to 1, right? Just so that way I kind of use it as a little bit of a, use it as a cushion to try to be a little more conservative in terms of drug dosing. That way you don't accidentally overdo it for the patient. Again, that's not something I want to put on the test, but just a little bit of something to think about. You will find that serum creatinine has a half-life just like anything else, and it does take time to get to steady state. So you will find that GFR may lag, which remember GFR is mainly calculated based off the patient's age, weight, gender, ethnicity in some cases, depending on the calculation. But the serum creatinine is one of the really important pieces there, and it can lag by a few days. So even though the patient's urine output might be acutely decreased, their GFR may still look okay, but then 2 days from now it may not anymore. So it will take some time there. So, and again, you will find certain calculations can over or underestimate GFR. Consider the fact that a lot of these calculations that we come up with, these different formulas, are based off of a study. All right, they took 50 people and they tracked their actual, creatinine in the urine over 24 hours, and they tried to figure out a mathematical formula that best estimated that. Right. So these things are always fraught with issues. You have to figure out kind of like who they were actually studying in the first place. So like if there's a calculation or a formula that you're using, but is only ever validated in white males, that may not be very helpful if you're looking at things like, black patients or female patients. And so you always have to take that into consideration for sure. Here is something you can see here. So if you imagine someone's GFR and then serum creatinine listed here over time, you'll see if as that insult actually happens there, you can see that the GFR will acutely decrease, but it will not be reflected in the actual creatinine clearance calculation because the serum creatinine takes time for it to actually get to steady state. So even though it's already diminished, you're not going to be able to detect that with just using GFR calculations alone. So in some cases, you might be using other things like urine output to help you out with this. There may be certain biomarkers we can test for in the future that can also help. But for the most part, the earlier you can catch this, the better off it's going to be for the patient's kidneys, and hopefully can reverse some of the damage that might have been done. So as I mentioned, if it's predicted, it can be avoided in a lot of cases there. So this is why you may see patients getting sort of aggressively hydrated prior to certain procedures. So for instance, if they're going to go get contrast dye, they may get, a couple liters of fluid beforehand to make sure that they can flush all of that contrast out from the kidneys to make sure it doesn't just stick around and cause nephropathy. We'll get into some of the specific drugs here in just a little bit. But again, make sure they have adequate fluid intake, that way you go ahead and make sure that the kidneys are perfused, at least from a hydration standpoint. And again, I apologize for the lawnmowers outside. I think they're right outside the window right now. But if you can, try to avoid those nephrotoxic medications. So for instance, that's why we look at things like trying to stop metformin 2 days before, getting contrast dye if possible, right? Not that the metformin itself is nephrotoxic, but because of the contrast dye being a nephrotoxin, you can want to make sure you avoid that sort of interaction there that can lead to issues. But yeah, you want to screen, identify for the patients, monitor that risk until it sort of subsided, whatever is going on that have led that patient to be at risk. We actually had a program that we initiated at Nemours, and it was called the Ninja Study, which I always love study names that go out of their way to get cool names, cool acronyms. But this is the Ninja Study, and basically it was a program where our nephrologists got a report every single day listing the patients who are on nephrotoxic meds, and they would go through to see if there's anything they can do, make sure the kidney function look good and all of that, just as one other way to prevent iatrogenic issues from cropping up. Because again, your patient comes in for, something like, a car accident, and they're being treated there, the insurance doesn't want to pay you if you cause them to have kidney injury, right, due to the drugs you gave them or something, right? Someone had a question. So is creatinine more sensitive to acute changes in the body compared to GFR, right? So GFR is not something we normally directly calculate. What we do is we calculate a creatinine clearance, which is a surrogate for that GFR, right? So, because again, creatinine is not the perfect marker to use there, but it's pretty good because it doesn't really have a whole lot of reabsorption or secretion. Whatever gets filtered generally gets eliminated in the urine. That's why we use that there. So again, it's a surrogate of GFR. So GFR itself is the actual filtration rate. It can go down pretty quickly, but your creatinine clearance calculations that you're using to estimate GFR will not change that quickly. It takes time for that creatinine to rise up, and that will then affect your calculations there. Hopefully that makes a sense. If not, let me know. Sometimes I'll use the terms interchangeably, creatinine clearance and GFR. Generally speaking, you can get away with that, but in this case here, I should make that distinction. The GFR is actually what's changing your creatinine clearance calculation. That does take that time to catch up because it takes time for creatinine to reach its new steady state. Let's see here. So, what can we do as in terms of prevention for acute kidney injury? Well, one, again, if you can identify and screen these patients beforehand, yes, that's great. And then what we can see here is hydration is probably one of the best things we can do for these patients in terms of preventing acute kidney injury. There's lots of other things that people will try. There's not a ton of great evidence to support it. I'll show you some examples here in just a little bit. Now, I don't know if I've gone over this previously, but just as a form of review, or maybe it's new for you guys, when I talk about fluids, we'll typically talk about them in terms, and this is IV fluids, we're talking about them in terms of crystalloids or colloids, and they're not alien species in my science fiction book that I'm currently writing. I'm not writing anything. But crystalloids are basically anything made up of salt, right? Some sort of salt-based solution. And so this includes things like your normal saline, right, which is 0.9%. Sodium chloride includes your lactated ringers, which is you see used a lot in surgery, things like that. These are always going to be recommended first line because they're cheap. There's not a lot of side effects associated with them. And these are great for just making sure you can tank up the patient and keep their intravascular volume, keep the tank full, so to speak. Colloids are typically either like starch or protein based, and this includes things like hetastarch, albumin based solutions. These tend to be more expensive, and they themselves can actually cause some renal dysfunction, so you do want to be careful there. But for the most part, just stick with your crystalloids. Relatively cheap, easy, and safe to use for the most part. So when talking about crystalloids, why is 0.9% sodium chloride normal? Like, what's so normal about normal saline? Basically, when you see that concentration 0.9, what that refers to is it includes a concentration of 0.9 grams of sodium chloride per every 100 mLs of water, right? When you calculate that out to how many milliequivalents that is, you can see here that basically is going to be 154 milliequivalents per liter of sodium chloride. Well, there's one sodium to every one chloride, so that means that you now have a solution that contains 154 milliequivalents of sodium and 154 milliequivalents of chloride. See, Kaylee's asking, when would you want to use a colloid over a crystalloid? Well, basically, there are certain situations where you may want to do this. The most common one that I will see is for patients who have hypoalbuminemia. One of the things you'll find is that they have low protein stores. You might find this in more like malnourished patients, sometimes, or critically stressed patients, but they may have low albumin levels. And when that happens, they have a hard time maintaining osmotic pressure to keep the fluid in the actual vasculature, right? Because that protein really stays there in the vasculature and it holds water in because of the osmotic pressure that it sort of has. And so in those cases there, you may want to avoid sodium chloride and instead replace the protein they don't have, and you can use albumin in those cases there. But I think I talk about that a little bit more here in just a little bit. But it's a very good question. All right, so, and again, I love these questions. They always come up every year, so you guys are on the right track in terms of your thinking, which is good. But someone says, is there a benefit of using lactated ringers as opposed to NS? Typically speaking, probably not. There's a little bit of nuance with the use there, and again, for the most part, if you go work in the ER or if you're working like urgent care, you're gonna use NS like 10 times out of 10, right? If you're in surgery, you're gonna see a lot more LR being used there, and so you're saying, well, what's the point? Well, and actually, I think I have a slide on LR just here. Actually, I don't. Right? I think I have another lecture that I give you guys during the clinical year where I talk about that. But basically, LR includes things like magnesium. It includes maybe, I think, a little bit of calcium. But the other thing it includes is lactate. Okay, that's why I call it lactated ringer solution. And so that lactate actually can be converted over into bicarb. So okay, well, why would we want to do that? Well, basically during surgery, there can be times where you can develop a little bit of an acidosis, right? You're cutting into tissue. You may have, periods of time where you might be hyperperfusing certain tissues that can develop acid, right? Like lactate, lactic acid can be formed there. So by giving the lactated ringers, the body can convert the lactate over into a bicarb and can help out with the pH, basically. Yeah, so Shelby's asking, are those milliequivalents calculated from the atomic weight of sodium and chloride? Yes, it is. And again, I'd have to go back to my undergrad chemistry to go through all of that. But basically, you can figure out for every gram of sodium or gram of chloride, really any gram of any ion, you can figure out how many milliequivalents that equates to. And some of that has to do, with this like charge and things like that, especially when you're dealing with potassium phosphate or calcium chloride, things like that, where it gets a little bit more funky in terms of all of that. But with sodium and chloride, it's usually pretty straightforward because it's a 1-to-1 ratio there. But yeah, so in those cases where you're thinking, okay, my patient may be more acidotic than, or lightly acidotic, then you can use something like a lactated ringers. We'll talk about other things that we can use, things like sodium bicarb that you can just put into the IV bag, and that can help out with the acidosis too. So most of the time it's just kind of clinical inertia. People just use what they've always used, and they just kind of stick with that. If you gave a surgical patient sodium chloride, are they going to have a problem? Probably not in most cases, but again, that's just kind of what they're used to, and that's what they still use. Although I'm sure if you talk to someone else, they'd be like, oh, that's entirely wrong. Of course not. We have to use lactated ringers. And, again, if there's good evidence to show it, then yeah, let's check it out. Let's see what's going on. But anyway, so as I was talking about with normal saline, it's 0.9 grams of sodium chloride per 100 mLs. That equal out to be 154 milliequivalents of sodium and chloride. So when you look at that, normal serum sodium is roughly 135 to 145. That's your normal serum value that most healthy patients should have. And it also comes out to be an osmolality of about 275 to 295 milliosmoles per kilogram, right? So this is your normal serum osmolality. Well, if you add 154 plus 154, which is going to be the osmolality of normal saline, comes out to be 308. 308 is pretty close to 295. So this is why we call it an isotonic solution. So normal saline is normal because it's isotonic to our blood, meaning if you put it into the vasculature, most of that fluid is going to stay right there. And because the sodium levels are pretty close to what our normal is. Okay, we're going to talk a lot about hypo and hypernatremia a little bit later on. That's generally why we call it normal saline. Now you may be saying, well, normal serum chloride is normally like in the 1-teens. Like, isn't this a whole lot more chloride than what you would normally have in your blood? And you're actually right. You can find patients who will develop a hyperchloremic acidosis from getting too much normal saline, right? That's usually liters and liters they have to get. But it can happen, right? So there's, it's not a perfect fluid, but it generally works pretty well for most things. Another thing you'll run into this concept is called free water, and free water basically means that it's water that doesn't have any sort of anything osmotically active in it, and it can kind of go anywhere. It can stay in the blood, it can go out into the tissues. Typically, it likes to distribute out into the tissues where the solute concentration is a lot higher. So just through osmosis, it'll like to go out into the tissues. And so when we are looking at something like D5W, you typically don't want to give D5 by itself to patients because even though it is isotonic at 253 milliosmoles per liter, it's all considered to be free water because all that dextrose, it's taken up into your cells. It doesn't like to stay out into the bloodstream to any great degree. So in that case there, all that water can just distribute out into the tissues. So we consider that to be sort of, it's isotonic. That fluid doesn't stay in the vasculature where we want it, especially like a dehydrated patient or something. If that doesn't make sense, let me know. I can try to go over it again if you need to. But again, good hydration. Typically stick with your crystalloids, sodium chloride, lactate ringers, whatever you like. I'm not going to have a fight about that. You'll just see more often than not. Most people use sodium chloride. People in the surgical realm tend to gravitate more towards lactated ringers. This is what they're used to. Now, there's some other things people have tried to use in order to prevent acute kidney injury, and that includes things like loop diuretics. They say, well, okay, well, if the patient's going to be at risk for not producing urine because of this injury, well, let's just give them something that's going to make them pee more, right? And so you would think that would work, but honestly, if anything, you're kind of putting more pressure. More pressure onto the kidneys and actually causing issues there. Even though you may think, okay, well, I'm decreasing the activity of these transporters, so maybe I have less oxygen demand. It's not actually found to be all that effective. And if anything, it actually increases your risk for things like ototoxicity. And you have like hearing issues that you can put on top of that. And not only that, but it decreases your intravascular volume. So you're actually causing more of a pre-renal problem for these patients you're trying to prevent an intrinsic issue with. So in this case here, really only use for loop diuretics would be to help get rid of extra fluid. So if they were had edema or something or ascites, you could utilize that to try to get rid of some of that extra fluid. People have tried things like vasodilators. And so I talk about dopamine in terms of its use as a vasopressor. Actually, a really low dose as dopamine can be used to try to dilate the renal vessels, and that allows for more blood flow to come in. And again, it's not really been found to be all that helpful there. There's another drug here called phenoldiazepam, which you may find used occasionally, and it's thought to be working as just a strict D1 or dopamine 1 receptor agonist, which would be activating dopamine receptors in the kidneys, increasing blood flow. But again, it's not really been found to be all that useful there, right? So a lot of times people try to use this stuff. They may think, well, it couldn't hurt the patient, but in some cases, if you're not doing any good, then what's the point of using it in the first place, right? Some people actually try to use antioxidants because the thought is, well, if I'm causing injury to the kidneys and it's going to be causing a lot of free radicals to form, causing oxidative damage, leading to tissue necrosis and apoptosis and all of that, let's use an antioxidant. And so there's a couple of things people will try, things like ascorbic acid or vitamin C. It's thought to, again, be a good antioxidant to help relieve some of that ischemic stress. And again, it's a water-soluble vitamin. Are you going to really get into trouble giving people vitamin C? Probably not, but it's has not really been associated with very good effects, as you'll see there. Not really consistent benefits there. And then another one you may see being used is called N-acetylcysteine or Mucomyst. This one I've probably seen most commonly being recommended by nephrologists if they're going to use it. I use it most commonly for acetaminophen poisoning. This is actually the antidote, which we can talk more about later in the emergency medicine section. We also talked about its use in CF as a mucolytic. And so we'll give this to patients, and again, it's thought to act as a free radical scavenger and can hopefully help prevent contrast-induced nephropathy in some patients. And that's where I've seen it most used often is patients who already have existing kidney disease. They need to get a scan done with dye, like they have a medical need for it, but they don't want to cause further injury to the kidneys. At that point there, it's like, okay, well, we don't want to cause any more problems. Is there any downside to using N-acetylcysteine? And in those cases, the nephrologist may decide to do that. So again, that's usually in conjunction with your specialist there you're working with. Interestingly enough, N-acetylcysteine also has a really high sulfur content, and so it has a rotten egg smell, which most patients do not find to be all that too appealing. One of my peeling eggs, I guess. I don't know. I remember one of my first jobs, one of my first tasks when I was an intern at a hospital pharmacy was to take vials of N-acetylcysteine, open them up, and then place them into smaller 3 ml aliquots for the respiratory therapist to use as a mucolytic. So I got to smell a whole lot of N-acetylcysteine there for a summer as an intern, and I'm now a year to it. It just smells like regular eggs to me, which probably is not great if I can't really tell the difference at home. Good thing my wife has a better nose than I do. Anyway, someone says, can you please repeat what you said about dextrose? I can repeat that. So the dextrose that so if I just gave like a dextrose bolus of like D5W to a patient there, that dextrose is not going to stay in the intravascular space. It's not going to stay in the blood vessels. It's going to be wanting to be taken up into the cells, just like normal dextrose from like, a hamburger or something like that would. So what's going to happen there is that insulin is going to rise. It's going to cause that glucose to be shuttled into your cells where it can be utilized for energy or fat storage or whatever the case may be, right? So when you give, say a liter of D5 to a patient, even though that solution is considered to be isotonic and should not cause a lot of shift of water, right? Because again, if I give something hyperosmotic, it's going to draw water into it. If I give something hypotonic, it's going to cause water to distribute out to the tissues. So it's isotonic, right? However, that dextrose gets taken up into the tissues and is going to take all that water along with it. So even though it's considered to be isotonic, quote unquote, based on the osmolality, it doesn't actually provide you any extra fluid in your intravascular space. So if I have someone who's dehydrated, they've been vomiting or having diarrhea, and they're intravascularly depleted, giving them D5 is not going to help them out. I mean, maybe they're hypoglycemic, it'll help, but it's not going to help them from a fluid standpoint. And that's why you see, like, for maintenance fluids, like maintenance IV fluids, you never see plain dextrose being given. Occasionally you might see, like, D10 being used for, like, a neonate, but for anyone older than that, it's usually going to be NS plus D5, right, as the most common sort of, like, maintenance fluid you'll see out there. Again, hopefully that makes sense. All right, going forward here. So let's see. So once we actually have the damage done, so let's say we're moving from a preventative sort of paradigm more to acute treatment. Most of the time, the treatment revolves around eliminating the insult if you can, right? So if it's a drug-related cause, get rid of the drug. If it's an infection, treat the infection. And supportive care is really kind of the best thing we can do. There's not a whole lot of things we can do from a drug standpoint to actually increase function. Sometimes we do require renal replacement therapy, which can be intermittent forms of dialysis. It could be continuous dialysis, which I'll talk a little bit more about later on. And if a patient is on dialysis, that's a really important thing to know, because maybe you've noticed this on your prescription assignments. If a patient has poor renal function, you'll notice there's a section just for adjusting the dose and the frequency of a drug. based on the patient's renal function. And one of the sections on there will be, if GFR is above 60, if it's between 30 and 60, if it's less than 30, it'll say on RRT or on dialysis. And that's really important to know because you do need to adjust that, because in some cases, the dialysis may be so strong that it's acting like a normal kidney, and then you don't have to change the dose at all. Sometimes you may be dosing less frequently, like dosing every 2 days or something like that. So that's a really important thing to consider is looking at a patient's med profile and trying to figure out what's appropriate based off of if they're on renal replacement therapy, if they're on intermittent dialysis, if they're on continuous dialysis, whatever the case may be. You'll typically see recovery within 10 to 14 days if you can get rid of the injury, but it just depends on the case there. And our goals there, if we can, again, as I mentioned, minimize the insult, reduce any extra renal complications, which I'm going to get into, and then try to expedite the renal recovery, which honestly, time is probably the best medicine here for these type of patients. If these patients are dehydrated, then we can try to get them repleted with more fluid. And again, if you can use oral therapy, that's always good, right? That'd be nice if you can use oral. However, if they're vomiting or maybe if they're unconscious, whatever the case may be, you may require IV fluids. And so you're going to find that isotonic IV fluids are recommended, because again, isotonic fluids are not going to cause a lot of shifts of water from the tissues into the intravascular space and vice versa. Whatever you put in terms of fluid into the intravascular space is going to stay there for the most part, which is where you want it, because these patients are hypoperfusing the kidneys. They're dehydrated. So typically we'll start out with some NS. Again, a typical bolus is around 20 mLs per kilo. For adults, it's like 1 to 2 liters. Just be careful because of these patients with existing kidney injury. They may not be able to process all those fluids. So you do want to be a little bit more cautious that they already have, edema and things like that, because you don't want to overload them, because that can lead to pulmonary edema in some cases there. If they're septic and they're really third spacing a lot of fluids out of the vasculature and into the surrounding tissues, they may require like 6-8 liters of fluid just to get their intravascular space filled up. So it can require quite a bit there. And typically your goal is to get into a map of around 65, which is a mean arterial pressure. Have you guys covered how to calculate mean arterial pressure? Let me know, and I can tell you if you guys don't know. And then urine output is usually, we like to be above 0.5 mLs per kilo per hour. That's kind of our goals in terms of like cardiovascular stability from that standpoint. Typically, when these patients are dehydrated, again, they're going to be tachycardic. That can be another thing you're looking at as well. Once you get them kind of volume repleted, then hopefully their tachycardia will kind of trend back down there. And of course, what you're looking for, things like pulmonary or peripheral edema. You're looking for things like electrolyte balances, normal glycemia are all things you're going to be looking for here as well. As I mentioned, if they're anuric or oliguric, maybe you want to start out with smaller amounts, as I mentioned, maybe 250, 500 mLs there. Also be careful if they already have like pulmonary or CHF insufficiency, because again, they may not be able to process the fluids as well. And then, as I mentioned, large volumes of NS can lead to hyperchloremic acidosis. This is more often an issue in patients who have like pre-existing acid-base disturbances. So if they're acidotic beforehand due to sepsis, then that could just worsen that. So again, you can maybe at that point switch them out for something like lactated ringers if they are, if they are acidotic from that standpoint. In some cases, you may utilize a lower concentration of sodium chloride. So for instance, you could do like half normal sodium chloride, which is 0.45%, and then add in some sodium bicarb to make up for the missing sodium there. Sometimes we'll do that. And then if they're anemic, obviously you want to give them some blood, so you can do that too. Again, I'm not going to get super into blood transfusions because it's not really my area of specialty, as it turns out. Okay. So as I mentioned, renal replacement therapy, it can either be intermittent or continuous, depending on what's recommended by the nephrologist and what they put there. Question. So why is it that you give patients with acute kidney injury isotonic fluids again? Because typically when you're thinking about this, they're generally speaking, you want to give your patients isotonic fluids more often than not. And really, it goes for like any patient. There are really specific instances where you're going to use hypertonic solutions, which I'll actually get into today. And then there are some instances where you might want to use hypotonic solutions, but that's less common, as you're going to see. But basically, when you have a patient who is dehydrated and they're hypoperfusing the kidneys because their blood volume is not where it should be, you want the fluid that you're giving the patient to stay in the intravascular space. And that is done by using isotonic fluid. So if I put a liter in that patient's blood volume, that leader is going to stay right there. It's not going to get distributed out into the tissues, hopefully, as long as they're not like third spacing, but it's going to stay right there for the most part. And that's good because that extra leader can then go into the kidneys and perfuse it, and then hopefully maintain some renal function there. It's not 100%, but most of that fluid is going to stay right there, if that makes sense. And if you need to, you can look back at like your physiology notes. I'm sure Professor Kaplan talked about, isotonic versus hypotonic, hypertonic, and how fluid shifts around with that. If you need to review, though, I can certainly talk more about that if you like. I have no problem going over that stuff as well. Now with dialysis, you're going to find the main indications here. This handy mnemonic, I like this one with the vowels A, E, I, O, and U. These are common reasons for dialysis to occur. So, for instance, if they have an acid-base abnormality, that can be fixed with dialysis. If they have an electrolyte imbalance, like hyperkalemia, that can be fixed with dialysis. You'll see it a lot in patients with chronic kidney disease as well. Intoxications, this is where I come in terms of toxicology. I will oftentimes recommend dialysis, which is sometimes a fight, or especially if you have someone who like overdoses on aspirin or lithium or something, and it's like 3 o'clock at night, on a Saturday night, and I'm like, okay, well, this patient needs dialysis, and the only nephrologist is like an hour away, and they're on call, and they don't want to come in to start dialysis, and they're, oh, can I wait till the morning? I'm like, well, I mean, the patient might be in the morgue by then, so maybe you want to come in tonight, so sometimes it's a tough conversation, but we'll do this for certain types of overdoses, for certain meds. You can also do it for fluid overload, and then also uremia. So these are typical indications for hemodialysis. Other things we can try to consider when looking at the patient's pharmacologic therapy includes things like the volume distribution for the drug, right? The patient is not filtering fluid effectively, they're holding on to it. That means you're going to have more volume out into the tissues, so that can affect volume distribution for things like hydrophilic medications, right? Want to look at the volume status to see if they're dehydrated or euvolemic, hypervolemic, things like that. And then look, especially antibiotics. This is one of the biggest interventions that I have to make when rounding on like in the ICU and things like that, or if I'm dealing with like these really kind of highly labile sort of patients that are in critical states, is looking at their antibiotics, because frequently you have to adjust them. This is where we do a lot of like therapeutic drug monitoring for vancomycin and things like that. And basically, it's a big thing, because you have to make sure that you're giving a big enough dose of the drug to actually treat the infection, but also looking at the frequency that you're administering to make sure you're not going to overdo it, cause worsen kidney injury, causing ototoxicity, things like that. Someone says, at what point would you choose between dialysis for these indications versus something less invasive like medication, such as with hyperkalemia or with fluid overload? A lot of that comes down to conversations between the attending providers, and frequently you're going to be including, you're going to be talking with things like nephrology. Nephrology is typically the ones that are going to be placing the hemodialysis catheters more often than not, and so oftentimes you kind of have to have their blessing in order to go along with it. So you can consider, like, for volume overload, you can try things like diuretics first. You can try like a loop diuretic. If you find that's not going to be effective or sufficient, then at that point you may say, okay, well, now I need something else, and then you call up your nephrology buddies and talk about it. So oftentimes they'll kind of give you a list of things you want to try first. And then you can, once that's kind of exhausted its ability to be effective, then you can kind of go down the dialysis route. It's certainly not something you want to make with a light decision, because it is pretty invasive. The HD catheters you have to place in there can be quite large, and can be a challenge, especially with hypotensive patients. But sometimes it's necessary. So especially if you're dealing with, like, if you're working like the overnight shift and you're in a more of like a rural type of community hospital, it can be really tough to get the nephrologist to come in. So they say, well, go ahead and try this until the morning time when I come in, and I can go ahead and do it then, right? So sometimes you have to have this kind of conversations, but other times, you're saying, no, this is emergent. I need this patient to have dialysis like right now. So just as an example, with something like a lithium overdose, I've had cases where basically, the normal treatment for like a lithium overdose is to give them lots of normal saline, right? So you say, okay, we'll give them lots of saline because that puts the kidneys in a state where it wants to get rid of lithium. We try that, right? You try that, and we still see the levels are rising, and we can't really do a whole lot from a GI decontamination standpoint. So we said, well, we got to do something for this patient, because before we know it, they're going to be seizing, And then at that point, it's very difficult to manage, and they might die from that, right? So that was an indication where I said, well, we need dialysis right now. We've exhausted other options. And that's kind of the general flow you kind of go through with those sorts of things there. I've had to have someone life flighted before. I actually had to make that recommendation for an aspirin overdose in a very rural area where they just could not do dialysis. There's just no one there from a nephrology standpoint. So they're like, well, do you want us to like life flight this patient? And it was kind of a hard decision. That was like my first day on call, I think, when I was in fellowship. And they're just like, so should we like fly this person out of here? And I was just like, I need to talk to my attending. I cannot make this decision, you know? So of course I go looking for the guy, and I think he was in the bathroom or something. I couldn't find him for like 30 minutes. And I was just like, this patient needs this. I'm like, okay, yes, please do that. And so I was worried I was going to get chewed out, but he agreed with my decision at that point. The patient did well. So that was a good resolution to that case there. Fun times of toxicology, I think. Anyway, again, I just like to bring it back to my experiences, but your mileage may vary for some of this stuff. Anyway, a lot of tangents today I'm getting on. I think it's probably because it's the end of the week for me. But so in terms of actual treatment for acute kidney injury, there's not like a lot you can do for like specific agents to treat this. There's not like a drug that treats kidney injury, unfortunately. More so you're managing the complications. That's really the biggest thing there. So in terms of diuretics, some things that people have tried before include something like mannitol. Mannitol is actually a kind of an interesting drug here. It's actually used as an osmotic diuretic, and so this is used parenterally. You'll probably see this more often used for things like traumatic brain injuries where they're having increased intracranial pressure. Or other cases of increased ICP, you may see that being used there. Interesting though, like it can actually cause acute kidney injury itself, so we don't often like to use this. Mannitol, I only bring this picture up here because it's really interesting because mannitol, if it's at a low temperature, or you think most hospitals, they keep it pretty chilly to keep bugs from growing. It has to be filtered because you can end up developing crystallization. So if you ever see a mannitol vial kept at too low a temperature, it'll crystallize out like this. And obviously you can't inject that into a patient. It could cause an embolus. And again, those are the crystals you can see. It's all the ones that we can't see that we'd be really concerned about. So it has to be warmed. Typically, most hospitals will have like a little easy bake oven sort of device that you can keep the mannitol in that keeps it warm. And that then keeps it in solution so that we can give it to your patient. Then we filter it to make sure no extra crystals that get in there and can cause injury to the patient. But not often used, but sometimes you'll see mannitol being used for increased intracranial pressure. And then sometimes loop diuretics are used. Again, these are typically going to be done for patients who are experiencing volume overload. This is really the biggest thing you're treating there. Any of the loops can be effective here. You'll find torsemide and bumetanide are just more potent in terms of the dose you're giving, but these are all equally effective here. And remember, ethylcrinic acid is good for patients with a sulfa allergy that cannot get something like furosemide. So that's typically what we go with. Torsemide and bumetanide can also interact with the sulfa allergy as well. So oftentimes you may find that patients become what we call loop resistant, where basically you'll find that the loops may be working for a while, but then all of a sudden urine output starts to diminish. Some ways we can get around this is either by, if they're on oral, Lasix, you can switch them to parenteral. Maybe try going up on the dose. And even in some cases, we'll do continuous infusions of loop diuretics. If you ever see someone on a Lasix drip, that's what they're doing there. And then some other things we can actually try are to use different agents. And so in some cases, we'll use things like thiazides with diuretics or with loop diuretics because they have a bit of synergy there since they're working at different portions of the nephron, which is very handy there. Remember, with your thiazides, if their creatinine clearance is less than 30, they don't really work with the exception of metolazone. That one still does retain activity. So that's a good point to know there. If you have a patient whose creatinine clearance is 15, HCTZ is not going to cut the or not going to be able to get the job done there. Metolazone will be used in that sort of situation. And again, why is this happening? Well, because a lot of it has to do with the renal compensation that happens here because the kidneys don't like to lose all that salt and water, even though you need to get rid of that fluid. So this is why you develop that resistance there. So the renin-angiotensin system is picked up and all of that. So again, you can try loops, get the fluid off. That doesn't work, then that's when you consider things like things like hemodialysis at that point there. You can try some drugs that work at the collecting duct, but often that's not usually necessary. More often than not, I'll find patients who are on a loop like furosemide plus some like metolazone, most commonly in terms of combination for loop resistance, and that does work pretty well. Okay, So the electrolyte management with hypernatremia and fluid retention, this is probably one of the more common electrolyte disturbances you're going to see happening here. If you can limit sodium intake, that's going to be helpful. So maybe if they're on NS, you switch them over to half NS or 0.45% sodium chloride. You could try things like loop diuretics, again, as we mentioned, that can help out with that. And if they are on renal replacement therapy, that is mitigated with that, because when you have someone on dialysis, it will help to regulate their electrolytes and get their potassium and sodium all back under control. I'll talk more specifically about hyperkalemia and how to manage that later on in the ER section. But again, if you recall, using loops, it will drop your potassium as well, because it does get rid of both sodium and potassium there. And then in some cases, you may find certain electrolytes are not effectively removed by renal replacement therapy. So this is mainly magnesium and phosphorus. This is more of a problem in patients with like brush injuries due to like maybe an accident, motor vehicle accident or something, rhabdomyolysis, things like that. In these patients here, you want to be careful to and avoid calcium. As you have really high phosphate levels, it tends to bind to calcium, and this is a problem we're going to talk about in chronic kidney disease too later on. They can tend to precipitate together, and so you can Google some pictures or GIFs of phosphorus and calcium precipitating out, and that can cause issues in the tissues for these patients there. What's interesting too is actually one of the electrolyte disturbances that can be caused by renal replacement therapy is actually hypocalcemia. The reason why that is because when you're taking all this blood out of the patient and running it through the dialysis circuit, you don't want that blood to coagulate and cause a blockage of that circuit, because then you have to start all over, you lose all that blood potentially. That can be problematic. So one of the ways they keep the blood from coagulating outside of the patient is to use something called a citrate anticoagulant. If you recall, looking back at your coagulation cascade, you saw that calcium was a powerful stimulant to kick off that cascade and cause the blood to eventually change, convert fibrin over, or fibrinogen over into fibrin. And so by using a citrate anticoagulant, it binds up the calcium that's there in the blood. So by the time you put it back into the patient, some of that calcium has been bound up, and then they maybe develop hypocalcemia. So it's not uncommon for patients who are getting renal replacement therapy to get hypocalcemia and then require extra supplementation. So lots of different electrolyte shifts that can happen here. You want to watch out for. So that's kind of it for acute kidney injury. Now I want to kind of switch gears here and talk about chronic kidney disease. Let's say we had one of those patients who developed chronic kidney disease due to, I don't know, something like extra protein supplementation or something, and see how we can manage that. Here we will see a lot more drug utilization that's available to us here. When talking about chronic kidney disease, again, this is where you can break it down into various categories here. Obviously, the more later stages are going to have much lower GFRs associated with them, where you can have patients who have a GFR of 2 or 3, right? It can be very, very low, almost completely non-existent in some cases. What are some of the complications you can run into with patients who do have chronic kidney disease? Well, you can run into some bleeding issues, right? Some propensity for bleeding there. You can run into, impaired ability to fight infections and platelet dysfunction. As I mentioned, you can't see hypoglycemia as a result of renal dysfunction because you can't clear insulin quite as well, right? You'll find things like GI bleeds are possible, decreased gastric emptying. Patients are not going to really want to eat a lot if they're kind of chronically uremic. It tends to cause a lot of nausea and vomiting. And then we'll also see neurologically things like peripheral neuropathies that can develop here. So obviously these are things we want to prevent. In terms of etiology, diabetes is probably one of the leading causes here. And then oftentimes what goes hand in hand with diabetes is hypertension, but certainly even things like glomerulonephritis can lead to this as well. And obviously if you can deal with some of these reversible risk factors or modifiable risk factors, I should say, that would be very handy. Things like diabetes, blood pressure, smoking, all of that would be very helpful to modify if you can to prevent progression of chronic kidney disease. This is another disease state where you can't really reverse time at all and reverse function, and you can just really try to prevent it from getting any worse if possible, slowing progression of disease. What you're going to find when these patients have chronic kidney disease, you'll see this loss of nephron mass. You'll see that they can actually develop glomerular capillary hypertension, so the pressure's too high, which puts extra stress on the system. And then obviously you'll see things like proteinuria. Patients with kidney disease, you can find they'll have that kind of frothy sort of urine they describe it as, and a lot of that's due to the protein that they're spilling out into the urine there. What's interesting is that you'll see that there's kind of a cycle here that happens where the initial injury that happens here tends to reduce filtration rate, which causes things like adaptive hemodynamic changes, which can then worsen things like glomerular blood flow. And so it's kind of a sick cycle here, whereas the way that your body is trying to treat, or the way your body is trying to handle that decrease in kidney function eventually worsens the kidney function even further, right? So things like, having that increased pressure on the glomerulus just causes further damage and impairs the ability to filter effectively. And so it is a very cyclical sort of disease state, which is why you want to interrupt it by doing things like getting their blood pressure under control or taking care of their diabetes and things like that. So I want to talk about some of the specific issues that can happen with these patients and ways we can manage that. So some of the complications here. So first off, we have anemia of chronic kidney disease. This is very commonly common occurrence. This is mainly because of the fact that the kidneys are responsible for producing erythropoietin. If you don't have erythropoietin, you can't necessarily have a strong stimulus to produce new blood cells there. And so these patients will develop a normochromic normocytic anemia, not because they can't produce the red blood cells, it's just they don't have the impetus to do so because their erythropoietin levels are low. And you'll also find the iron deficiency is pretty common in these patients as well. And again, anytime you're giving something to a patient to try to stimulate red blood cell production drug-wise, you got to make sure their iron is under control, because if you don't, it doesn't matter how much you give them. If they don't have the iron to make the hemoglobin, it's not going to do you any good. But reasons why patients become deficient can include things like they have just decreased GI uptake, they getting frequent blood testing, which again can drop their hemoglobin. Blood loss from the renal replacement therapy too can be a common one. And as I mentioned here, you'll find that they have increased demands by giving erythropoietic stimulating agents, or ESAs, which we'll talk about here in just a little bit. But again, this is the main reason why these don't work as well, as if you don't get the iron sort of fixed. We're also going to see there is a lot of chronic kidney disease related bone and mineral issues here. You can develop with something called renal osteodystrophy that happens here. This has a lot to do with things like PTH levels, calcium, and phosphate. And I think I have a whole slide just about that. Yeah. But has a lot to do with vitamin D production, calcium, and phosphate, along with parathyroid hormone. Those are a lot of the big players that you're going to see there. And so basically what happens for these patients is that they'll develop decreased renal function. So one of the things that will happen there is that they will hold on to more phosphate because they can't clear it from the kidneys as well. Well, that extra phosphate, as I mentioned, likes to bind to calcium. So now you have hypocalcemia as a result of this hyperphosphatemia. Well, low calcium levels will then trigger off the parathyroid to release more PTH, which causes more calcium and phosphate reabsorption from the kidneys. Also will start to stimulate your osteoclast as well. And then you also can't activate vitamin D as effectively. So now you have two kind of stimulants on the parathyroid, including low vitamin D, and you're going to have less calcium in the bloodstream. So all of that leads to more PTH. And you can see this sort of sick cycle that happens here, where eventually the patient can develop like really brittle bones that are easy to break, right? And so fractures can be a risk for these patients as well. So a whole host of things. Again, why I say the kidneys are so important, even though they do seem sort of insignificant in terms of size and all that, but they are quite important, which I'm sure is a fact not lost on you guys and gals. Remember when we were talking about vitamin D previously, that vitamin D gets activated as a two-step process. So whether you're developing it in the skin from sun exposure, or whether you're getting it from your diet, whether it be choline or ergocalciferol, it has to undergo a two-step activation process. First, in the liver to, I think, the 25 hydroxy vitamin D, and then down to the kidneys for the dihydroxy vitamin D. Again, if you don't have good kidneys, you can't produce that. And so that is going to be a problem for these patients. All right. So to go along with that, they start to develop this hyperplasia because of the parathyroid, because it's kind of working overtime in that case there. And so then they become kind of resistant to calcium and vitamin D therapy. And they get this osteitis, fibrosa cystica, which is basically this high bone turnover disease, where they get even worse erythropoiesis happening there. So that worsens the anemia, the osteomalacia, osteoporosis. So yeah, not a great thing. We like to interrupt that if we can. Other things can include uremic symptoms, or that can include altered mental status, weight gain, cold intolerance, these neuropathies that can happen here. And then certainly you'll see from a physical exam perspective, you can see things like edema develop. You'll notice decrease urine output, proteinuria, things like that as a result of all their renal dysfunction. So how do we manage that? How do we take care of this? Well, one, we'd like to delay or prevent progression of disease, which means getting their blood pressure under control, getting them stopped from smoking, getting their diabetes under control, all of that. And ideally, we'd like to limit their need to get on hemodialysis, peritoneal dialysis, or as a last stopgap here, actual renal transplant, because again, that's just going to be much more complicated. You know, having hemodialysis, doing that 4 hours, 3 times a week. So 4 hours Monday, Wednesday, Friday is a big impediment to their lifestyle, and you find a lot of non-compliance with this. So if we can prevent their need to go on dialysis, that's going to be helpful there. Again, as I mentioned, address those primary causes. So I'm sure you will get this with Dr. O. This is just a quick pictorial example of the differences with dialysis. You can see here with hemodialysis that basically you're taking the blood out of the patient, you're sending it to a dialyzer, which is basically a filter that's able to remove waste products, remove excess fluid, remove excess electrolytes, and then it shunts it back into the patient there. Patients may have a fistula that is implanted that makes it easier to connect the hemodialysis ports to. In some cases, like in the hospital setting, you may find that they have a catheter placed that is designed for hemodialysis. And then here's another example of something called peritoneal dialysis, where basically you'll have a dialysate solution that you can infuse into the peritoneal space. You let it sit there for a while, so that way it can kind of equilibrate with the blood and try to pull out excess stuff like urea and things like that. And then you will drain that out, and then basically it's kind of urine coming out at that point. And so you'll see that it will undergo several exchanges for periods of time, and then they'll do that every single day basically, so many of our exchanges. So again, both are pretty disruptive to patients' lifestyle. So again, these are things we'd like to avoid if we can. Peritoneal dialysis can actually be really challenging because patients have a tendency to get infected in here, and so drug dosing for peritoneal infections can be quite challenging. And sometimes we'll actually even put antibiotics into the dialysate solution itself. But a little bit of a tangent. Anyway, things we want to do for these patients includes keeping their diet limited in terms of protein, especially when their GFR starts to get like less than 30. And then you also want to limit sodium intake as well. We'd also like to get them exercising and stopping their smoking habits, which maybe we can use some nicotine replacements or varenicline or maybe bupropion, who knows. And so here's some other things that patients should probably be on. So in terms of diabetes with chronic kidney disease, you really want to make sure you're utilizing ACE inhibitors and ARBs, because again, while for patients with chronic kidney disease, abrupt initiation of an ACE inhibitor can cause decreases in GFR chronically, these are going to help spare kidney function and keep it going for longer. So we know this is going to help them out quite significantly. And basically what you're going to be looking for here is watching their GFR, making sure their creatinine clearance doesn't, decrease acutely. And you're also going to be watching out for their potassium, because these patients may not be able to clear potassium very well. You got to be really careful there in terms of that, making sure they're not going to become hyperkalemic, because then they're at risk for all kinds of arrhythmias, right? If they are on metformin, then typically you want to get them off of that at around a GFR of less than 30. So that's going to be probably one of the main reasons why someone's not going to be a good candidate for metformin. Is going to be their renal dysfunction there. Again, this is kind of the old way we used to look at it in terms of just serum creatinine numbers, but we don't do that so much anymore. It's just focusing on the GFR. In terms of blood pressure, we'd like to get them to, usually like a target of less than 140 over 90. Some people recommend even lower than that, so less than 130 over 80. As I mentioned, ACE inhibitors and ARB should be first line for these patients, especially if they have diabetes. And you'll oftentimes find that things like thiazides are not going to be all that effective on their own. And so you just have to manage just like you would for other disease states, right? So if they have a history of MI or CHF, they're going to be on a beta blocker, right? Which again is going to help out with the hypertension, but at the very least, they should be on ACE or an ARB if they have diabetes. So for the anemia, so now let's get into some new drugs here. So for patients with anemia, we want to be able to increase their oxygen carrying capacity, right? So more hemoglobin molecules. We want them to obviously decrease their signs and symptoms of anemia, so have more energy, less fatigue, all that sort of stuff. And ideally, we'd like to have them reduce the need for transfusions, right? Because again, they may have religious concerns that preclude them from getting transfusions. You may run into cases where patients can have allergic reactions to blood that's being infused. So if we can get them to produce their own hemoglobin, that would be fantastic. And we do that with erythropoiesis stimulating agents, or ESAs. Some of you might be familiar with those as being abused for doping scandals and things like that in professional sports. But here we're going to use it for our clinical purposes. And then we'll look at iron supplementation. Again, here we're going to be using hemoglobin as our ultimate measure of efficacy. So what can we do for these patients here? So basically, we're going to consider all patients with CKD who have a hemoglobin between 9 and 10 to be good candidates for ESAs, right? So if they're lower than that, they still count. And basically, what we want to do is to make sure that we give them enough to get them to a hemoglobin around 10. And then once they're there, we will go ahead and then discontinue it. I apologize, my phone keeps buzzing off. I have a new phone, and so I'm still trying to get the work on getting it to where it will not bug me during lectures and whatnot. But anyway, so here what we're going to find is the reason why you don't want them to have too high of a hemoglobin, even into what we would consider to be sort of like normal levels for like healthy adults, is the fact that you can tend to see that the blood becomes more sort of viscous and more kind of causes like the blood to kind of sludge a little bit, and that leads to less it causes it to be more viscous, and thus it does not flow as well in places like, I don't know, the brain, right? So things like cerebrovascular accidents are a risk when you kind of push the hemoglobin too high for these patients. Just the flow just isn't there like it should be for maybe someone who's otherwise healthy and has a hemoglobin of 14 even. So especially if it's above 13, that is a huge risk for that. So we want to make sure we don't cause our patients to stroke out because we gave them too much of an ESA. And so, and again, these drugs here we're going to talk about in more detail. You can give it to them all day long. It will not make a difference if their iron is not correctly supplemented. Okay, we'll talk about iron supplementation here in just a moment. But the two big ones you're going to run into include epoetin alpha. This is usually under the brand name Epogen or Procrit. And then there's another one here called darbepoetin alpha or Aranesp. As I mentioned, these have black box warnings for things like death, MI, stroke, VTE. All that is related to pushing the hemoglobin too high and leading to things like blood sludging and causing impaired flow through these different organs and leading to death. I believe there's been some cases even of cyclists, like professional cyclists, who were utilizing ESAs and basically caused their blood to become so rich in hemoglobin that when they were cycling and they got dehydrated, the blood just couldn't flow very well, and they actually ended up stroking out and dying. I believe there's at least one case of that. And there's some increased risk for cancers, things like breast cancer, lymphoid cancer, things like that, which makes sense because these are stimulating cell lines to replicate and reproduce. So you could see some risk with that, but it's really low. Dosing ranges may vary depending on the agent you're using there. So like epoetin, you might be using 3 times a week. Darbepoetin, I think, has a longer half-life, so you can use like once every month or so. So that may be something they get when they come in for their dialysis, right? So they're coming in anyway for dialysis. Go ahead and give them their injection at that time. Not a problem. As I mentioned, the main adverse effects there can be things like hypertension, which makes sense based off what we talked about, and it can actually cause some vascular access thrombosis just due to the blood sludging and causing issues like in their fistula or in their port or something like that. So, as I mentioned, iron status really needs to be corrected here. However, this is really tough for these patients here because iron itself is not a fun thing to take orally, and oftentimes they're not going to have good absorption from the GI tract anyway, which is going to be a challenge. But make sure to not only keep their iron under control, but also things like B12 and folate, because again, these can be diminished, especially after renal replacement therapy, due to just kind of, you're not going to get every drop of blood out of that circuit back. So over time, 3 times a week, you can see how that can cause some issues there. And as I mentioned, only about 10% of iron is going to get absorbed in these patients, and so you may find that oral intake is just not going to be sufficient on it. So we have a couple of different oral preparations here. We have things like ferrous sulfate, ferrous gluconate, ferrous fumarate. If you see a ferrous on there, then basically it's going to be an iron product. I don't know if you've ever seen there's the cyclical form of iron. They call it a Ferris wheel. I don't know if you guys have ever seen that one before, but that's a fun one. Kidding. And then we do have some IV preparations as well that we can utilize. So things like iron dextran, sodium ferric gluconate, iron sucrose, or furomoxetol. I probably see iron sucrose probably used most commonly nowadays. I tell you a funny joke like the Ferris wheel, and I don't see any comments. I'm assuming my internet connection is down. I check and it's still going. So you guys must be laughing too hard to actually type anything. Anyway, so why is iron not great for these patients here? There's a lot of GI complications. Ferris Bueller, perhaps, yeah. That's good. You have no words. That's why you type them out. That's fine. Anyway, so from a GI standpoint, iron is not great, causes a ton of constipation, abdominal cramping. Over 50% of patients may end up developing issues like this. Not only that, but it can cause blackened discoloration of your stools. So you got to warn patients about that, because if they otherwise see blackened stools, they may be thinking something like a GI bleed, that's melena, but no, that's just the iron causing that to occur there. With the IV formulations, these are not without risk. It's good because IV formulations have 100% bioavailability, which is great, but they can run issues in terms of like allergic reactions that can happen there. Things like hypotension and dizziness. Like, I'm shocking all you guys with my dad humor. But yeah, so with the allergic reactions, hypotension, typically you'll see that if patients are being infused too quickly, that can end up dropping their blood pressure. So typically this will be a couple hour infusion. These patients are getting their iron products there usually every couple months or so. I'm a mad lad for sure. Anyway, you can see things like arthralgias as well. So not ideal. If you can get orally administered iron, that's great. But again, for a lot of these patients, it may not be able to be keep up in terms of pace of absorption. So as I mentioned, use oral if possible. It's going to be a lot cheaper, not related with any infusion reactions there. But for especially the renal replacement therapy, they're probably going to need at least a couple of doses of IV iron there. And basically, you're monitoring that every 3 months or so while they're on ESA therapy, monitoring their hemoglobin every 3 months. Again, this is not going to be a quick fix sort of thing there. Can't forget about the OG cause of black stools, Burger King's Halloween milkshakes. I'm not familiar with that, but I feel like I'm going to need to go down a Google rabbit hole here after lecture. But yeah, so remember, erythropoietin is not going to be a fast-acting sort of thing. It's going to take a couple of months for it to really kick in, which is why I always I always love it when, like, my nurses, they're calling for patients EPO, and they're like, "Where's the EPO? We need to get it going stat." And I'm just like, this is not a stat drug, lady nurse. You can just wait a little bit, and they don't like that answer. So I normally say, okay, I'll work on it for you. I think it's coming out right now. Oh, it is coming out right now, but they usually hang up after that. Anyway, and so again, we're monitoring a little bit closer as we first initiate these things, because again, we want to make sure there's not going to be any issues from that standpoint. But usually every 3 months or so is how we monitor that. Moving into bone-related issues here for these patients. Again, we want to try to disrupt sort of that cycle with with parathyroid hormone and calcium and phosphate and all of that. Try to keep the bones as nice and dense as possible for these patients. Typically, they're a little bit older, so osteoporosis is a concern anyway. And typically, we like to keep their calcium and phosphate in sort of normal ranges there. And so there's something we normally look at. It's called the calcium phosphate product. If you can multiply a patient's calcium times their phosphate, if it's less than 55, that's generally good. If it gets above that, then we start to worry about things like tissue calcification and whatnot. And then again, we're also monitoring things like their PTH levels as well. From a non-pharmacologic standpoint, dietary phosphate restriction is important here. And so again, we talked about how you want to make sure they get enough protein, but a lot of phosphate comes from protein, so you got to make sure you're not getting too much from that standpoint. It does make proper protein supplementation difficult, as I mentioned there. And again, certain things that are high in phosphate include things like beer, cola, peanut butter, things like that. Again, I'm sure you can find a full list elsewhere. And again, too, like, your dialysis patients do require higher protein requirements anyway, so it can be quite challenging. And for a lot of these patients, you're going to find that just through diet alone, this is not going to be sufficient. We're going to need to do some other things to try to make sure they're not absorbing too much phosphate there. Some patients even do require parathyroidectomies, but hopefully we don't have to get to that point if we can intervene with some pharmacologic measurements here. So what we can do is give them a phosphate binder. Basically, this will bind the phosphate in the GI tract and prevent it from being absorbed. Obviously, this would be needed to be taken around mealtime when that phosphate's going to be in the GI tract anyway. So these are typically the common ones you're going to run into. So typically, first line therapy is going to be calcium based. And you're like, well, wait a second. Like, you said the calcium is binding up the phosphate in the blood, but now we're doing the GI tract, and that's good. So we can just basically bind it up, prevent it from being absorbed, and then just eliminate it through the feces. Most commonly, you'll use calcium carbonate because that's cheap, over the counter. That's just the same Tums you would get, from any grocery store or anything like that, pharmacy. And then another one here we have is calcium acetate. This is called Foslo. Makes sense because what it's being used for. And this one would be a prescription product that you may be recommending for these patients here. And again, just binds up calcium or binds up phosphate in the GI tract and prevents it from being absorbed. Now, if the patient was hypercalcemic due to their condition, you may find that that's not maybe a good idea to be giving them more calcium. So what we could do instead is to use a non-calcium based phosphate binder. So that would include things like sevelamer carbonate and lanthanum carbonate. Those are used pretty often if calcium is not going to be a good option. And then we can also utilize aluminum hydroxide, which we've seen before as an antacid here. But you do want to be careful with aluminum because these patients tend to have a tendency to accumulate aluminum, and having too much in the CNS can actually cause some neurotoxicity. So we want to avoid that if at all possible. So they can get calcium acetate, calcium carbonate is fine. If they can't, probably stick with sevelamer or lanthanum, and if that's not possible, then we can use aluminum hydroxide. So, as I mentioned, you're going to find that early on in CKD that the calcium is typically going to be low because all that extra phosphate in their blood is binding up that calcium. So in those cases where they're hypocalcemic, calcium acetate, calcium carbonate, great options you can use there. You're going to find that calcium carbonate is going to be a little more soluble in acidic medium, so you get that prior to meals, and that will help out with that. Oh, that's very funny, Alyssa. I'm glad you thought that was serious. That's my favorite thing, if I can get someone to think that was being serious there for a moment. Hopefully I can at least correct it so that way you're not thinking about that for the test or something. See, someone said, will calcium carbonate help bind to phosphate and increase calcium, or will it just bind to the phosphate? Yeah, so a little bit of that will be able to be absorbed. Yes, you just find a little bit of calcium being absorbed, but most of it's going to be utilized to bind up that phosphate in the GI tract. No worries about being behind. That's the whole point. You can kind of watch it at your own pace for sure. So early on when they're hypocalcemic in the grand scheme of chronic kidney disease, those are good for them because that can actually boost up the calcium levels a little bit. With later stage chronic kidney disease, you'll find they can't really eliminate calcium all that well through the kidneys, and so they'll tend to be hypercalcemic, and that's where things like sevelamer can be utilized there. And as I mentioned, aluminum-based products we try to stay away from as best we can because it's not something that's pulled off by dialysis. They can cause neurotoxicity, so not great to introduce that heavy metal if we don't need to. So adverse effects, just like we talked about calcium previously, like a lot of constipation is going to be seen with that. Hypercalcemia could be something you want to be monitoring for. And of course, I mentioned the aluminum toxicity there. It can also bind or kind of compete for the same binding as iron, so you can actually find worsening anemia from there. So that's why you want to go ahead and avoid aluminum for most cases. The other big thing too is that these patients' medication lists are probably going to be pretty long because they're probably going to have hypertension, diabetes, etc. So you want to watch out for those drug, food, and drug interactions. So especially with like calcium, any of these phosphate binders, they can interact with many other oral medications. They probably either want to take their other meds an hour before or 3 hours after their medications. So that way you can go ahead and separate them out and prevent them from having any interaction there, right? So they're taking other oral meds an hour before the phosphate binder or 3 hours after the phosphate binder. Vitamin D therapy is, again, very important for these patients here. As I mentioned, ergo and cholecalciferol has to be converted in that two-stage process in the liver, then in the kidneys. And so if they cannot form it in the kidneys, then it's not going to do any good. They can take as many units of vitamin D as they want. It just doesn't do anything. So in that case, we give them calcitriol or rocatrol. This is already active 125 vitamin D. Again, this is typically more expensive than regular old ergo calciferol, but the benefit here is that one helps to stimulate some calcium absorption, which is good early on, but it also suppresses PTH secretion. That's really the big thing there. We like that because we will lead to less bone turnover. So that's really the kind of nice thing from that standpoint. However, the downside there is that, especially with more progressive kidney disease, you can find that having more active vitamin D actually leads to more calcium and phosphate reabsorption at the kidneys, and then that can actually worsen that calcium phosphate product and lead to things like tissue calcification. If that is the case, if someone has hypercalcemia, hyperphosphatemia while on calcitriol, we can switch them over to something like paracalcitol instead, and that basically will activate the PTH receptors, but it doesn't have the same effect that vitamin D has in the kidneys or in the GI tract, so it decreases calcium and phosphate reabsorption. That's good. So if someone could not be on calcitriol, then you switch them over to paracalcitol, and that's a good option for them. Another one here, we have cinacalcet or Sensipar. This one is going to be basically sensitizing the PTH receptor, so they're more responsive to the effects of calcium, and that overall will then lead it to think, okay, we have enough calcium here, and it will reduce PTH secretion. So sometimes I'll see that used as an alternative, paracalcitol. Sometimes I don't know that I've ever seen the two in combination necessarily, but yeah, so those are for patients who calcitriol is not a good option. You can use one of these two. Okay, that's it for chronic kidney disease. I still have some more time, so let's talk about specific causes of drug-induced kidney injury and things we can do about them, right? Again, how these will manifest include a lot of things like acid-base abnormalities, electrolyte abnormalities, hematuria, decreased GFR. That's obviously going to be the most common thing you're going to be monitoring for with drug-induced kidney injury. And so, as I mentioned, about in terms of community-acquired drug-induced kidney injury, about 20% of hospital admissions are due to some sort of acute kidney injury due to drugs, right? So if they're coming in for acute kidney injury, drugs were a cause in about 20% of those cases there. In hospital, though, it is much higher. It's much more likely that the drugs we're giving the patient has caused a kidney injury. And that can include things like your chemotherapy drugs, antivirals, antibiotics, all of that. So this is why you have to watch for this, because the insurance company isn't going to want to pay for a kidney injury that you caused, and so that's going to be a problem for the hospital and for you. So you want to make sure you're monitoring for this. It might be on some of the metrics that you're being measured on as you're working, if you are in the hospital. So as I mentioned, most common manifestation here is that decrease in GFR, and you'll notice that by an increase in serum creatinine and BUN most commonly. It was actually kind of interesting, though. This is a concept I never really thought about till I was learning from another pharmacist on rotations. But they talked about how you can sometimes still have renal tubular function, or dysfunction can occur without actually having a loss in GFR. So what that means is that even though it may look like the patient's processing fluid normally, it looks like the GFR is good, sometimes you will find that the renal tubular function has diminished. So that way it can't really reabsorb things like it should, can't excrete things like it should, and so we kind of call them like dumb kidneys, meaning that you'll still have things like, you'll be losing potassium and sodium in the urine, even though the GFR looks okay, things like that. So in some cases, the GFR may not be the end all for your monitoring for kidney function there. And of course, you can see the typical symptoms that come along with that, malaise, anorexia, etc. So what we're also going to be looking for is going to be urine output reductions, right? So if it's like an adult, if they go down below 0.5 mLs per kilo per hour, you'll see things like volume overload, hypertension. This happens a lot with things like contrast-induced nephropathy. It's that CI in there, NSAIDs, ACE inhibitors, things like that. And then for proximal tubular injury, this will end up seeing a metabolic acidosis because you can't reabsorb the bicarb that you're filtering, so you just end up peeing it out. You can see hypophosphatemia, hypokalemia. You'll see this a lot with drugs like amphotericin B, which we talked about as an antifungal drug that causes just leaching of a ton of electrolytes through the kidneys there. And then with distal kidney injury, you'll typically find there's going to be more of a problem with concentrating the urine. You'll typically see that you cannot concentrate it very well. You may be getting very dilute, copious amounts of urine being produced just because it can't reabsorb water effectively. So what are drugs that are typically associated with things like structural or functional alterations? And so specifically for acute tubular necrosis, these are the things kind of probably in descending order of things I think are really important to know about. And some of these, which I talk about more specifically, those are the ones I want you to kind of key in on for studying. So I'll go over some of these more in more detail here, but these are just kind of a list for your education here. But certainly aminoglycosides, radiographic contrast dye, cisplatin, amphotericin B, cyclosporin, tacrolimus. These are the big ones we're going to be talking about, along with the antiviral drugs here. Also talk about some of our osmotic drugs that can lead to osmotic nephrosis. So that includes drugs like mannitol, IVIG. These are like basically hyperosmotic solutions you can give to patients that will cause renal injury. And then we've talked about sort of the functional pre-renal kidney injury that can occur, and that is related to the hemodynamic changes induced by things like ACE inhibitors, NSAIDs, and like that, which we'll get into more details on. This is sort of like the overview. In terms of obstructive nephropathy, you can run into things like a lot of your antiviral drugs things like acyclovir, things like indinavir. Some of these drugs, if we haven't covered them yet, they're talking about them specifically here. We'll cover them later. So don't fret too much about that. And as I mentioned, methotrexate can have a tendency to precipitate out if not kept in a solution that is basic enough or gets too concentrated. And then nephrolithiasis is something you'll see with things like sulfonamide drugs, tramtarine, indinavir, things like that. For actual glomerular disease, this is not as common that you're going to see, but can occur with things like lithium and NSAIDs. This is also a big reason why we don't use gold-based compounds anymore due to the kidney injury that it was causing there. And then as far as acute allergic interstitial nephritis, this is more seen with things like certain antibiotics like penicillins and ciprofloxacin in particular. Those are things you want to watch out for. Again, I'm giving you a lot of information here. Don't get so lost in the weeds. I want to talk more specifically about the drugs I want you to know for testing purposes. This is more so just to show you kind of the breadth and depth of different kinds of kidney injury that can be happening via the drug. It's not just enough to say, oh, the drug caused kidney injury. It's like, well, what type? Like, what kind? How do we manage that? Things like that are the things we want to look at. Vasculitis, remember things like hydralazine for patients that are more likely to develop that lupus-like syndrome. That can lead to kidney injury there. Amphetamines are a big one that can cause issues here. And even things, kind of oddball things like cholesterol emboli can occur with things like warfarin, for instance. So if you're experiencing or having a patient develop this tubular epithelial damage, a lot of this is related to sort of direct cellular toxicity, or it could be related to ischemia that's occurring due to hemodynamic changes here. And you'll find that it tends to either get localized either to the proximal or the distal tubular epithelia. So either you're going to see proximally, you're going to run into a lot of issues of the renal tubules not being able to reabsorb things effectively. And then distally, you're going to find that's a problem in terms of being able to concentrate the urine. So you can kind of run into both issues on either side there. And then you also find that if you just have cell degeneration happening, then yeah, you're going to start to get catheter developing that can cause obstruction. And you get those kind of muddy brown casts you might find on something like urinalysis, for instance. So we're going to talk about acute tubular necrosis as sort of being the most common presentation for drug-induced kidney injury, especially in the inpatient setting. This is something we're always trying to avoid and why we always have to monitor renal function for these patients, especially if they're on known nephrotoxins. And so these are kind of the big ones we're going to be talking about more explicitly, and that includes things like aminoglycosides, the radiocontrast media, which we'll dive into, cisplatin, which we remember from our talks on oncology, amphotericin B, which is a anti-fungal drug we talked about previously, and then foscarnet, which I believe I talked about briefly in the antiviral section there. And we'll talk about some of the osmotic ones as well. So I'm not having time to get through all this section here. I think I'm probably going to go ahead and cut it off for today and let you guys get on with the rest of your day there. We'll kind of talk more about the specific agents when we meet next time, so that we can kind of just keep them all together and talk about how to kind of manage them differently between the different agents, see what might be a factor for one versus another and how they present there. So I think that's all I'm going to do for today. I'm sure some of you are not going to be too sad about that. Do any of you have any questions? I think next time we meet is going to be next week on Tuesday. It looks like we have another Tuesday, Wednesday session there. Yeah, no problem. Thank you guys for joining me. I appreciate it. You guys are awesome. Thank you for getting me over 600 subscribers. I really appreciate that. I was like up to 605. That was very nice of you all. So now if you could just get some kind of bot farm scheme set up and get me to like over 1 million, that would be really, really handy for my self-esteem. That would... Don't do that. Come by my subscriptions, honestly. You guys have a great day. No ads for you guys. That would be bad. All right, you guys have a good one. I will see you all next week. Have a great weekend.